So thank you, Steve, for telling us more about the STAR material. It is a very different device. And when I first came upon the device and learned more about it, we're used to seeing lumens in devices. We're used to seeing holes and tubes and things. And this is not a tube. This is, as you saw, a microsphere, porous, soft material. And I think that's a very novel way to think of it. The bigger issues we have in glaucoma has always been fibrosis. We know this, and we, of course, try to mitigate it by chemical means and toxic means and cellular toxic means, which, of course, can be pretty effective, but they have potentially their downside. And I think the idea of looking at a material, not only the material itself, but also the way it's designed, is, I think, what the effort with iStar Medical has been. So I do want to, point out some of the differences with this very soft material. I think the conforming nature of it, as Steve has mentioned, I think will afford it to sit well within the eye and prevent it from potentially, having an issue with regards to corneal issues. So let me start with providing some data, because we can talk all we want about the design and the technique, but in glaucoma we need to see data. And I will say this is the first in human data, and the role of this study, which I will present, is really, to look at the safety of the device and look at the delivery characteristics of how can the device be placed in the eye. So whenever you do first in human studies, we always have to, go in with a bit of courage. We have to, of course, ethically enroll patients. We have to be very cognizant of the unknowns that are there. At the same time, if we have data to show, then it's nice to see, what the efficacy can do and what the early results are. So I will say that this is, again, early. We have a small group of patients will present, but Christoph will then show what's happening next and concurrently with these studies in terms of ongoing work. I will show my disclosures, and I do consult with iStar, and I have performed numerous surgeries. For those of you who missed the winter, that's a picture of my road near my house with just a little bit of snow here today outside. Not today, but the previous day. So like many first-in-human studies, this is a small pilot study. It's a prospective study. It's an interventional, basically, study with a single arm. And the objective, again, was primarily to look at safety as well as look at efficacy, primarily looking at IOP at 6 months. Now, we are fortunate to have longer-term data, which I'll share. We have one-year data we're going to share for the first time here. And those are some of the important endpoints. We have the typical standard endpoints that we see in clinical studies, which include diurnal IOP, looking at these at 6, 12, and 24 months, medication use success rate, and importantly, we are looking at endothelial cell loss both early and also long-term as well. And we'll go through some of the communities we have as well. Now, the patient population we're looking at were mild to moderate patients with primary open-angle glaucoma who were uncontrolled in topical medications. We enrolled 25 patients, and we have subsequent follow-up at 2 years, as we mentioned. And the technique has been described very nicely by Steve. The surgeons here include Christophe, who's on the panel here, as well as Philippe Denis from France, and myself. I was fortunate to be the first surgeon to implant the device, with the first device going in the early part of 2017. Our sites were in Panama and India, and we had, I think, a well-recognized safety monitoring committee here. I see some of our members in the audience as well here. So we had, again, a classic standard first-in-human design with the proper approach. Inclusion criteria, I think nothing overly surprising with inclusion criteria. Patients over 18, primary or secondary open-angle glaucoma, mostly primary open-angle glaucoma. Patients had to have an open angle, grade 3 or 4, uncontrolled on medication. So everyone was on medication and on drops, with diurnal pressures between 21 and 35 and enrollment with consent as well. We did exclude, again, some of the typical patients that we're concerned about, neovascular glaucoma, patients who had very severe damage in the central 10 degrees, patients who had prior glaucoma surgery. So these patients had not had prior glaucoma surgery, and patients, of course, needed to be followed up without further surgery down the road. Patients who had intraocular inflammation were excluded as well. So let me just go through some of the results. And again, I want to point out that these patients, again, these are medicated IOPs. We have to be careful when we look at studies, because many studies will report washed out IOPs. Some studies will report medicated IOPs, and there's plus and minus in doing either approach. These patients many of them had different severity of glaucoma, and so these patients were medicated coming into the trial. A typical split between male and female. You see most patients were 69, but we had a pretty large range of patients, from younger patients to older patients as well. You can note, because of the location of these studies, we had no Caucasian patients, and we can certainly discuss the role of ethnicity in success of glaucoma surgery. There's obviously a lot of discussion in this, but many patients were patients we typically would at least associate with potential risk for increased scarring, with patients of African descent, Asian, and Hispanic as well. 61% left eyes, and so the mean baseline medicated pressure was 23.2 plus or minus about 3 millimeters of mercury. Medication lowering was about 2, as you see there, and we had 25 patients. We have one patient who passed away, unfortunately, not related to surgery in this study as well. So this is I think a fairly good representation of patients who have serious glaucoma disease with potentially maybe even a higher risk population. Steve's already talked about the surgical procedure. We as surgeons found the procedure was deliverable. We were able to deliver implants in all 25 patients successfully. There were no serious intraoperative complications. A gonioscopic lens was used, a typical angle approach is used, in a small incision. Again, there were no mitomycin or 5-FU used in this space, and all patients had performed the procedure as a standalone. So, unlike other studies where we have cataract surgery as a confounder, these were only standalone patients, and patients were carefully monitored with gonio imaging and photography and UBM to look for migration. And over the course of the 1-year results I present, there was no implant migration after implantation. So this is basically the classic IOP, the money slide. Diurnal IOP medications, you can see the drop from 22.2 to 14.2, and then 15.6 at 1 year. Again, I want to mention that again, this baseline IOP is medicated, so no washout. And the medications range from 1 to 4 medications on average of 2. You can see that no patients required further glaucoma surgery at 1 year. So this data is all the patients except for the patient that passed away in the midst of the trial. You can see 75% patients were medication-free, so 3/4 of patients had no medications, and the average patient, though, overall was 15.6 millimeters of mercury. We often talk about that mid-teens as being that kind of golden number to think about for patients with moderate disease. A lot of our trabecular meshwork procedures are typically higher, into the higher teens, and our subconjunctival procedures certainly can get very low, but of course carry some increased risk. So mid-teens for an ab-internal mixed procedure, for me at least personally, I can speak for myself, is a place that I really like to be. We have a 33% drop, which I think is a fairly substantial drop in IOP for a standalone procedure. If we break down the medication use, you can see that between pre and post-op, no patients were on 0 medications. Everyone was medicated pre-op. As I said, it was an average of 2 medications, and you can see that majority of patients were on 2 or more medications in the study pre-op. After surgery, you can see that 3/4 of patients were on no medications, and 25% of patients were on medications. So again, a fairly different shift in medication use, which for patients is an important metric when we look at success and outcomes. So here we see just a breakdown of patients with medications. Again, 1/4 of patients were medicated with a mean reduction of 26%. The 3/4 of patients who were on no medications achieved a 35% drop, down to an average of 14.8. So it's nice to tell patients, I like to think about these metrics when I talk to patients. Patients don't think about mean IOP. They think, what's the percentage chance of me being off medications at target pressure? So again, small study. I want to caution generalizing, but looking at data like this, we may say 3/4 of patients, there's a 70% chance of getting pressures down at target on no medication. So these are different ways to think of the data as well. We've already talked a lot about endothelial cell loss. We didn't talk about it a lot before, but now, of course, with SATPAS we have. And this is just the ASCRS statement. Both Steve and myself were involved with the ASCRS task force, where we had cornea specialists and glaucoma specialists looking at the data and providing information. As we said, we really felt there was a strong correlation between device position and cell loss, and this is basically the statement, and you can read that statement. I think it's a very obvious question to ask, what about MINIject? The similarities are that both devices end up in the supraciliary space. But as we said earlier, I think that we need to think about some differences with the device in terms of where it's positioned, the material, the design, the softness of it, how much of the implant is in the anterior chamber, and what angle it protrudes in the anterior chamber. It's nice to see this in the small cohort of patients we had no migration. And when we look at the data, this is just, again, based on a 1-year data. And I will caution with endothelial cell counts, as we all know, the variability and the variability in not only measurements, but also in the analysis of the endothelial cell density centrally. But you can see both centrally and peripherally, there was no significant difference. Now, this is a 1 year, and certainly we need to see longer-term data to be assured of this. But it's been reassuring, certainly in the early postoperative period, that the mean change was not significant from baseline. And this data will continue to be followed. No doubt further studies will involve this as well. As I said before, there were no serious intraoperative or postoperative adverse events, no further glaucoma surgery, and the corneal endothelial cell health was maintained as mentioned at 1 year. So this is just a summary slide. Again, as we said, we have a substantial drop in pressures without the confounder of a phaco in this group of patients in a pilot study. Most patients were medication-free and overall achieved a 30% drop at 1 year. You know, for me, the most important thing in doing this study was, can we do the surgery? Can surgeons implant this device with this novel approach? Remember, we're basically laying the device into the space rather than pushing it in. It's a very clever design, and I want to again congratulate the iStar team, both the R&D team and medical team as well, who's been very attentive to these approaches. We also found again that intraoperatively we didn't have serious complications, and postoperatively as well. So that's a very important aspect again of an early trial like this. It's difficult to confer too much on long-term efficacy, and I will grant that criticism, and this is important. This is where Christoph will talk to us about some of the trials that will be ongoing. So I think it's reasonable for me to come up here and say, I think this is promising. I think this is promising, and that's probably the most I will say in terms of what to conclude from the technology. And I think we have to be mindful of that as well. But 1 year data is very strong in terms of what we see. We're very interested in seeing patients followed up to 24 months, which we'll be seeing as well. But we have to, of course, think about this again in longer term in a variety of patients in different settings as well.